From Microbe TB, this is Infectious Disease Puscast, episode 83, recorded on Monday, June 23rd, 2025. Hello, everyone. I'm Dr. Daniel Griffin, and joining me today is Dr. Sara Dong.
Hi, everyone. I'm Sara. Welcome to another Puscast. References, as always, are available in our show notes at microbe.tv, the home of our growing multimedia empire. I figured I guess by the time this is released, hopefully things will have cooled down, but tell people to stay safe and stay cool. It seems like the heat wave is basically everywhere. It's a bit miserable.
It is hot. And so, Sara, on Friday, we lost air conditioning in most of my house except like the downstairs area. But apparently I'm not enough of a New Yorker because I called and I'm like, I know I've got that contract where you're supposed to come out in like 3 hours, but it's really hot. I'm sure you're getting lots of calls. My wife and kids are out of town. So if you could come by Monday before they get back, that would be great. And it was like a pause. They're like, really? Because I'm thinking like all like the older, people, for me, it's like bringing me back to my childhood. Next thing, watered down Tang and tuna casserole, Growing up on South Shore, Long Island with no AC, it's just the good old days, just laying there sweating, unable to sleep. So
yeah, I'm from the South where I feel like people, it's very normal for everyone to have AC for the summer, and if it breaks, then you are very anxious to get it restarted. So, anyhow.
I remember when I was in Taipei, Taiwan, and this was 35 years ago, and there was a group of us, and we all would talk about saving up enough money so one person would buy an AC, and we would all hang out at their house, and we never had that kind of money, but.
That's a good plan. Yeah. Well, welcome everyone back. Puscast is a review of the infectious disease literature for the last 2 weeks that we found interesting or entertaining. So on to the literature, shall we?
All right. Well, I will jump in with our viral section. Remind everyone to listen to This Week in Virology, both the clinical updates and the deep dives. There's a lot going on, so we'll keep talking about it, and we'll keep delivering actual science. But I enjoyed this. So for those following this story, we have the accepted manuscript "Premature Demise of the Milwaukee Protocol" by Rodney E. Willoughby in CID. And this is a Dear Editor correspondence that starts with paraphrasing of Mark Twain. Reports of the demise of the Milwaukee Protocol are greatly exaggerated. It's a brief and interesting rebuttal with an optimistic tone. Per Dr. Willoughby, survival does happen and is not necessarily neurologically devastating. We struggle to reconcile Dr. Jackson's degeneration of neuronal processes in a fixed virus model with functional survivors who marry, bear children, hold jobs. Broad-spectrum antivirals, biologics, and gene therapy are being developed by other optimists. In the meantime, we are happy to compare the MP, the Milwaukee Protocol, to another therapy when Dr. Jackson has one. So, I enjoyed that.
And I think, I think I only had one viral paper, but I pulled it because tis the season. So this is an MMWR, West Nile virus and other nationally notifiable arboviral diseases, US 2023. So we are in arbovirus season. So this paper summarized the 2023 data for our domestic arboviral disease cases. So the 6 nationally notifiable diseases include West Nile virus, Powassan, lacrosse, Jamestown Canyon, and St. Louis encephalitis, and Eastern equine encephalitis. So this is through ArboNet, our national arbovirus surveillance system. In 2023, there were 2,770 human disease cases reported, including about 3/4, so 73% of those patients were hospitalized, and there were 208 or 8% that led to death. And so West Nile virus was the most commonly reported. It accounts for 95% of all the reported cases. And then most of these happen in the window of July to September. There were 3 West Nile virus cases among patients infected through organ transplantation through 2 donors. The next one up was Powassan virus. There were 49 cases. I thought I would just point out the distribution for that is a little bit longer. That was April through December for reported cases. And for children, lacrosse virus was the most common reported, and most of those cases were classified as neuroinvasive. So overall, the number of these arboviral cases was up from 2022, but lower than 2021, and that was driven a lot by a large West Nile virus outbreak in Arizona at the time. So I thought I would just plug, we did a febrile episode last year talking a little bit about arboviruses and lacrosse virus, and particularly in pediatrics. So if folks want to hear about example clinical case, they can check that out.
It was an interesting outbreak. That was Sedona, I think. I remember that area there. A bunch of cases.
Yeah.
And maybe some dogs. I think some dogs got sick too. All right. The article, Investigation of Associations Between the Neonatal Gut Microbiota and Severe Viral Lower Respiratory Tract Infections in the First 2 Years of Life, a birth cohort study with metagenomics, published in The Lancet Microbe. So very cool stuff here. So they've got this baby biome study, the BBS, and it's a prospective birth cohort. They've enrolled mother-baby pairs between January 1st, 2016 and December 31st, 2017 at 3 UK hospitals. In this study, they included baby biome study babies, so BBS babies, with a sequenced first week stool sample and successful data linkage. Stool was collected in the first week of life for shotgun metagenomic sequencing, a catchy name there. The investigators examined the following microbiota features: alpha diversity, Chow-1, Shannon, and Simpson indices, community structures, cluster partition against Medoides method. So alpha, beta, and gamma diversity can get complicated, but just think of alpha as the richness of different species in a community. Cluster partitioning against Medoides methods, basically grouping data into clusters, as we will see described in this study. So just get all that kind of complicated stuff out of the way. They're going to look at the richness and the clustering of the diversity of the microbes in the BBS babies. The team used electronic health records to determine the link between microbiota features and lower respiratory tract infection hospital admission incidence in the first 2 years of life. They've got over 1,082 newborns, half of them, so 564 born vaginally, the other 518, the other half born via C-section. They found that greater gut microbiota diversity in the first week was tied to lower rates of this lower respiratory tract infection hospitalization, so lower viral, so little v LRTI hospitalization. So they identified 3 microbiota clusters, right? So we talked about how they're going to cluster them. So we've got cluster 1, this is a mixed composition, and then cluster 2, dominated by beneficial Bifidobacterium brevi. Both clusters occurred in all infants regardless of delivery method. So then they identified this cluster 3, and this is only babies born vaginally had the cluster 3 microbiota, and this was predominantly beneficial Bifidobacterial longum. So having not 3, but cluster 1 and 2 microbiota independently associated with higher rates of lower respiratory tract infection than cluster 3. And really talking about a 3-fold hazard ratio, so 3-fold increased risk. Now, figure 2 is my favorite. They've got this nice clustering, and then cluster 3 and some vaginal birth babies. So you can go through, you can actually see all the different say bacterial species in the microbiota, but you can really see this clustering, right? So if those of you that are actually looking at the figures, maybe this will be up on YouTube. If you look at this figure, and you figure 2, and you compare A to B. So in A, and this is for those of you listening, driving around, pay attention to the road. In section A, if you look at the C sections, you've just got this cluster 2 and you've got cluster 1, but none of 3. And then you look at vaginal births, and you've got over 100 in the cluster 2. You've got over 200 in the cluster 1. And then you've got 242. So a huge chunk, more than a third, in this cluster that you did not see in those born through C-sections.
It's very cool.
I found this very exciting.
Yeah, that's really cool.
So maybe we got to take those, because I know there's been discussions about taking C-section babies and somehow trying to contaminate them with vaginal microbiota. I don't know, contaminate, maybe enrich them. I don't know. What would be the right word? Taking somehow trying to like correct the microbiome. I don't know.
Yeah, I don't know. We need to work on our market. Find a good.
Because we got to market
term.
this. You got to be like, come to our hospital where if you get a C-section, we will correct the microbiome. But
optimize.
Yes, I like that.
That's a good one.
All right, I'm going to share a WHO updated Mpox guidelines, clinical management and infection prevention and control for Mpox living guideline, May 2025. Right, so this keeps getting updated. But this is WHO, lots here, but according to the guideline, individuals with acute Mpox infection or at risk of complications should be managed in a healthcare facility and provided with enhanced supportive care. Only the mild, uncomplicated cases should be managed at home. They go ahead and they give advice about gloves and gowns, medical masks, eye protection, respirators required during aerosol generating procedures, and also in poorly ventilated rooms. So you just need to keep that in mind when we think about transmission. For patients being managed at home, the WHO no longer requires isolation if lesions are fully covered and the patient wears a well-fitting medical mask, even if they're in close contact with others. So wearing that mask when they're in close contact with others. And the guidelines introduce 3 new clinical recommendations applicable across all healthcare settings. We run through these. Mothers with Mpox are encouraged to continue breastfeeding while limiting direct contact with their uninfected infants. Mothers who have recovered from Mpox may resume breastfeeding and direct contact once the lesions have fully healed, and think about keeping them covered. People with HIV who are newly diagnosed with Mpox and are on antiretroviral therapy naive, or have had a prolonged interruption of ART, should get going on that ART without delay.
Perfect. Mpox came up in our faculty meeting today. All right, I will take us into our bacterial section. Be sure to listen to This Week in Microbiology. The paper I have for you first is from the New England Journal of Medicine, Crinibacterium diphtheriae, Outbreak in Migrant Populations in Europe. This paper was an assessment of cases of toxigenic Crinibacterium diphtheriae infection that were reported in 10 European countries from January to November of 2022. So I think sort of in the summer, people were noticing a surge of cases in reception centers for migrants in Europe. And so they used whole genome sequencing and antimicrobial susceptibility testing on the isolates from patients to evaluate phylogenetic relationships and antimicrobial resistance genes. So 363 toxigenic Crinibacterium diphtheriae isolates were identified among 263 patients, with clinical data available for about 96% of those. Of the isolates they had, there were about 78% who had cutaneous diphtheria. 15% or so had respiratory diphtheria, with about 3% having a pseudomembrane, and then a small proportion, so 9 of the patients, or 2.6%, had both cutaneous and respiratory symptoms. And so, I think folks probably think about respiratory diphtheria and the pseudomembrane, but I thought this is just a good reminder that there are or can be cutaneous cases with ulcers that may or may not have this kind of grayish membrane as well. But what's important here is that even though those patients with cutaneous disease may not have severe complications, they can play an important role in transmission. And they do have some images in figure 2 in the paper. I realize I didn't put it in the document here, but people can take a look at that. There were 4 major genetic clusters, and they shared a little bit about the ERM-X gene and PBP2M and BLA-OXA2 genes. But basically, the distribution of these genetic clusters showed repeated cross-border spread. And so this was the largest collection of cases seen in like 7 decades. And, the paper shows the importance of sharing genomic data. So during this outbreak, countries were doing that to help identify these main genetic clusters. And so they don't quite know the distal origin of the events, but it is thought to be linked to low vaccination coverage in countries with political unrest or, disturbed public health systems that allow for local reemergence. And also, those are probably the factors that are really motivating them to migrate elsewhere. And so I did include some of the images where you can take a look at the different types of isolates and clinical presentations. They're lumped by, asymptomatic, cutaneous, respiratory, or the combo, for example. And then there's kind of a nice chart that shows for the migration patterns, country of origin, the reporting country that the isolates were identified in, and, sequence types. It's very, very nice. So I sort of unintentionally picked a couple of things this week that have febrile episodes. So I will just plug, we did a couple episodes on vaccine preventable illnesses because the current climate, I will say. And we specifically had an episode on diphtheria 1 or 2 episodes ago, and an experience from West Africa and an outbreak there. So if people want to refresh themselves on diphtheria, that's another resource that you could use along with this.
Yeah, this is great stuff. I think, one of the things that really strikes me, Sarah, is, we're always taught like this, diphtheria, this pseudomembrane, but we're seeing here only 15% had respiratory, only 3% had a pseudomembrane. Really, this is, and the images are great. I brought up the New England Journal while you were talking, just seeing in one of the figures, we had these ulcers on the arm, actually, and then some other lesions on the hand, and not really stuff that I would have normally jumped in on.
Yeah, you wouldn't have immediately thought of diphtheria, which is, that's really, I thought this was really interesting, and probably is going to continue to be issues and have outbreaks in various places all over the world. So
yeah, I think we need to start teaching diphtheria a little bit different, saying most of the time it's a cutaneous ulcerated disease. And by the way, rarely you get that pseudomembrane. So, All right, weekly oral cycling antibiotic treatment, a new antibioprophylaxis regimen for recurrent UTIs published in CID. So first we'll start with a little bit of background. So we recently saw the publication of the state-of-the-art review, Recurrent Uncomplicated Urinary Tract Infections in Women by Advani et al. Current guidelines do recommend continuous low-dose antibiotic prophylaxis as the most studied strategy for preventing recurrent UTIs, so R-UTIs. Despite limited evidence, this approach remains widely used, though it carries a well-documented risk of emergence of antimicrobial resistance. So here the authors have implemented a weekly oral cycling antibioprophylaxis strategy, a WOCA, W-O-C-A. What do you think of that?
Yeah. Just throw that in my notes. I won't even explain.
Oral cycling antibioprophylaxis. So what is WOCA? What is this WOCA idea? This regimen involves the alternating administration of 2 different oral antibiotics taken once weekly every Sunday. So on week A, patients receive antibiotic A. On week B, patients receive antibiotic B with the choice of agents based on prior urine cultures and patient tolerability. So you're sort of alternating, So to explore the applicability of WACA in a broader population, they conducted a quasi-experimental before and after study in 34 adult women with 4 or more UTIs per year. No neurogenic bladder and spontaneous voiding. So the median age was 64. Okay, that makes sense. Interquartile range 54 to 81, so right age group. 12 of 34 were immunocompromised. Okay, that's a little twist. 6 of 34 had urolithiasis. 2 of 34 were obese. All right. The most frequent pathogens were E. coli, 24 of 34. Klebsiella pneumoniae, 2 of 34. 7 cases were polymicrobial. The most commonly used WACA regimens were fosfomycin sulfixime, fosfomycin nitrofurantoin, and fosfomycin pivmesilinam. Okay, so you're sort of alternating. Like this week you take fosfomycin, next week nitrofurantoin, this week fosfomycin, back and forth, or you can be doing that second one. It looks like in this study, fosfomycin was always sort of one of them, and then we've got the 3 choices. So the mean follow-up of 781 days, only 2 patients experienced adverse events requiring modification of the regimen. They observed a significant reduction in annual UTI episodes from a median of 7.5 down to 1. That's impressive. A 7-fold reduction in the annual UTI episodes using this WACA approach.
Yeah, it's interesting. I feel like patients often ask if they should be doing something like this because I think intuitively folks feel like it kind of makes sense. But yeah, I haven't done a ton of alternating. I know other people who also sometimes do the like a month of one, a month of other. I feel like I haven't quite done that, but I also try to get them off of the preventative therapy whenever I can. So maybe I'm just more have been focused on that more than alternating agents.
It is interesting, right? Because they do point this is broadly done. This is recommended in the guidelines. Limited evidence. This is interesting, but again, this is a pretty small study, 34 adult women. Impressive if this is something that, can be replicated. And again, they talk about older folks, nitrofurantoin, some issues with GFR and the rest.
Mm-hmm. Yeah.
Expense issues with fosfomycin, that little sachet that gets put in the water. So
yeah. And I am wrapping us up in Bacterial. I pulled this paper from CID. What is the impact of anti-enterococcal empirical therapy on survival of patients with enterococcal bloodstream infections? So I thought this is an interesting paper. So this is from this is a retrospective multicenter study. They took all hospitalized patients 2011 to 2019 with monomicrobial enterococcal bloodstream infections. And they examined to see if they received anti-enterococcal therapy within the first 48 hours or not, so after they got their blood culture. The primary outcome was 14 and 30-day all-cause mortality. They had 758 patients with enterococcal bloodstream infection. 342 of those received targeted active anti-enterococcal therapy. They did abbreviate it in the paper, but I'm just going to say it out loud because there's a lot of E's and it's easier that way. So 342 who received the targeted active anti-enterococcal therapy within 48 hours. As far as the breakdown of the isolates, it was about half and half. Enterococcus faecalis was the cause in 51%, and E. faecium was 43%. The ampicillin resistance was identified in 44% of isolates. Only 6% were vanc resistant. The main sources, not surprisingly, were intra-abdominal, which was about a third, 34%. Urine sources, 21%, and catheter-related was another 21%. About a third of the patients had sepsis and 8% were classified as septic shock. And so the take home, 14-day mortality was 24%, 30-day mortality was 42%. They did find that a high number of comorbidities and enterococcal bloodstream infection without an identified source, but not sorry, making sure I'm not mixing up my acronyms, but not anti-enterococcal therapy. So those were some independent predictors of mortality, but there wasn't a significant mortality risk associated with getting that anti-enterococcal antibiotics in the real or adjusted analysis. So if you looked a little bit closer, so of the 31% of patients who, for example, received the active anti-enterococcal antibiotics within 24 hours of onset, that did not affect their survival in the multivariable model. So, a trend towards improved outcomes in patients who got those anti-enterococcal antibiotics, but it really didn't, based on this study, improve their survival. And those patients who got that very early anti-enterococcal agent within 24 hours, actually, interestingly, in their subgroup had increased mortality, but I think that's probably just a reflection of their comorbidities and sort of baseline severity. There are some, the usual drawbacks to a retrospective study, but I thought the other thing is interesting. It's such a low number of VRE cases. So, I feel like often people are thinking about VRE more than VANC-susceptible enterococcus when they're adjusting their regimens up front. So a little hard to take away too many conclusions for this. There also wasn't a ton of info on things like source control, like was their catheter removed, and so on, other factors that are obviously very important. And so hard to tease out how much of this is really because did they get that anti-enterococcal agent or not, or is it, how sick they were when they come in, how many comorbidities they have, having a source that's not controlled. Our usual ID stuff.
All right. Well, moving us into fungal. I don't know. Are you done with season 2 of The Last of Us,
Yes.
Sarah?
Yes.
A little bit of a cliffhanger. I can't leave us right there. Oh, no. I won't tell anyone what happened at that cliffhanger, but I guess what we're going to have to wait till April of 2026 to find out what happens. So.
Yeah, I kind of wish they did these 2 seasons together, but I kind of know the story from the video game. But
don't tell me.
I won't.
Okay. Spoilers. So fungal, The Last of Us season 2. It's gone. It's over. You can binge that if you haven't so far. But we have the article Estimated Burden of Coccidiomycosis published in JAMA Network Open. These results come from a cross-sectional study using 2019 reported case data. Models estimated the occurrence of 206,000 to 360,000 incident symptomatic cases of cocci in 2019 in the U.S. That's a lot. 10 to 18 times the number of cases reported through national surveillance. So there's a lot more going on out there. They're pointing out here. This study estimated 18,000 to 28,000 cocci-associated hospitalizations and 700 to 1,100 cocci-associated deaths in 2019 nationwide. They conclude that the estimated national burden of symptomatic cocci in 2019 was 10 to 18 times higher than the number of cases reported through national surveillance. Better awareness, diagnostic testing practices, and reporting are needed to improve patient outcomes and enhance our understanding of cocci epidemiology.
I have a little cocci shout out in my next one. I pulled this paper from Lancet ID. Allora FIMM for the treatment of invasive fungal diseases in patients with few or no therapeutic options, a single-arm, open-label phase 2b study. So for those who haven't heard of or haven't thought about recently, Allora FIMM, it is the first orotamide antifungal agent. It works by impairing the fungal pyrimidine biosynthesis and leads to cell death. And so, as you heard in the title, this was a single-arm, open-label phase 2b study of patients who were at least 16 years or older. They recruited patients from 22 centers in 11 countries. There's some info in there about exploring dosing. So based on PK data from the first 25 patients or so, they simplified the dosing from the weight base that they started with to some fixed dosing. And their primary endpoint was a global response rate. So that was based on a composite of clinical, radiologic, and mycological responses. So that was the global response rate at day 42. It was determined as a success, so complete or partial improvement in all three components, or failure, stable disease or progression on any one component, or death from any cause. There were some secondary endpoints like global response rate at day 84 and the all-cause mortality at these time points, 42 and 84 days. They enrolled 204 patients in the window of 2018 to 2022, and 203 patients were treated with Allora FIMM. So what did they use it for? The pathogens in this study were largely Aspergillus, so 101 of the samples, and that included 22 that were azole-resistant strains. Lamentaspora prolificans, so that was 26 of the pathogens. Scedosporium was 22. They had 41 cases of cocci, and then there was a mishmash of others for the remaining 12. So there was a successful global response in 29% at day 42 and about 27% at day 84. The successful global response with stable disease that was included in the definition of success was seen in 75% of patients at day 42 and 63% at day 84. And I'll talk in a second about that stable versus sort of success. And the all-cause mortality all-cause mortality was identified in 24 patients at day 42 and 33 at day 84. One of the takeaways is that there were medically significant LFT changes, so that these were adjudicated to at least potentially be due to Allora FIMM in 10% of cases. And of those, they modified the dose in 7%, or they stopped the drug in 3%. So that's an important safety concern to watch for. Like many other drugs, there was reports of GI intolerance as well. This is more info on Allora FIMM, which we didn't have a ton of, so that's great. All of these patients also, to point out, had proven invasive fungal disease due to these filamentous or dimorphic fungi, or they had probable invasive aspergillosis. These responses were seen in patients at all levels of immunosuppression and also in kind of various periods from diagnosis to starting the antifungal. And just to point out, so 40% of the overall cases were considered high immunosuppression, so hematologic malignancy, stem cell transplant, and then 31% were, quote, moderate immunosuppression, so that would be solid organ transplant, the non-hemalignancy cases, and some other immunosuppression. So you can see the details of that in Table 1. But just to point out, these are not surprisingly immunocompromised patients and patients who don't have other options. So 54% had some failure of available therapy. 25% had known or predicted resistance to all the licensed agents. And so you can see the reasons at the bottom of that table of why they were reaching for Allora FIMM. And kind of the last thing I was going to point out is, so the patients who had azole-resistant aspergillus and other drug-resistant organisms had success and were doing well. The one point kind of related to that is that day 42 is based on, I guess, the regulatory precedent for antifungal drugs. And I think all of us know that we often need much longer than that to know how your patient's doing and if they're really responding. And we may need more time than that to really understand the therapeutic effect. And that's true at 48 days, but also probably even at 84. And so, for example, for coccidioides, there's, no successful global responses were recorded at those time points in the study, 42 and 84. But that's because the relatively slow rate of changes in antibody titers basically makes it impossible to demonstrate that mycological clearance within the main phase of the study. But then if you look at those who were classified as stable disease, 95% of the patients with cocci had that at day 42 and 85% met that at day 84. So super interesting. Hopefully something that, I think we're still trying to figure out who are the right patients to reach for this, but a lot more data than we had before.
All right, the article Antifungal Therapy in Candida Infective Endocarditis, a comparison of echinocandins and other treatment regimens in a nationwide cohort study published in CID. So I've got this nice graphical abstract where it kind of goes through. And really, the aim of this retrospective national study was to compare the outcomes of echinocandins in relation to other antifungals when you're going to treat Candida infective endocarditis. So the cases come from the Swedish Registry of Endocarditis, 1995 to 2019. We've got 3 cohorts. So cohort 1, cases treated with echinocandin backbone therapy. You can see not huge N's here, an N of 21. Cohort 2, cases treated with amphotericin backbone therapy, that's 22. And then cases treated with an azole backbone therapy, and that's an N of 8. And they're going to look at primary outcomes, treatment failure, in-hospital mortality or relapse. They're going to look at secondary outcome measures, 1-year all-cause mortality. Basically, cut to the chase, no difference in in-hospital mortality, relapse rate, 1-year mortality seen in patients treated with echinocandin-based therapy compared with other regimens. They conclude that, but if we actually look at the raw data, not particularly excited about what I'm seeing here for the azole groups, right? So just to give you raw numbers. So primary outcome measures for treatment failure, this is in-hospital mortality relapse, echinocandins 32, amphotericin 38, but azole was 62%, small numbers. Now, second outcome, right, that's 1-year all-cause mortality, echinocandin 24, amphotericin 19%. The azole was 60% again. So it's one of those tricky things when you have small n's and then you say, oh, we didn't really see any difference. Well, you may not have had the numbers to see that difference. All right, parasitic. Be sure to listen to This Week in Parasitism. We're starting sort of our spring-themed episodes, so check those out. And sitting right here on my desk, getting ready for like a deep read and a deep treatment on an upcoming This Week in Parasitism, we have the article, and I've actually got the uncorrected proof, so by the time we discuss it, it'll be all fancy and corrected. But does schistosome infection affect behavior through the gut-brain axis, published in PLOS NTDs, using 2 cohorts of 3-week-old female mice, they're mice. They measured levels of anxiety, fear, compulsion, spatial learning, and spatial memory between schistosome-infected and sham-exposed mice. Schistosome-infected mice showed higher levels of anxiety in the open field test, reduced spatial learning in the Maris water maze task. I see you're checking that out there. You're going to have to tell us all what that's all about. Enhanced memory retention in the novel object task. And then all the mice, they did the same on the marble berry task, right? So it depends what you're testing. So they compared the fecal microbiomes, right? So is it really the schistosomes, or is this happening through the microbiome modulation? So they used 16S ribosomal RNA gene sequencing at 2 time points during the chronic stage of infection. Each cohort started with unique microbiota, which showed marked changes in the comparative or beta diversity of their microbiota after exposure. In both cohorts, at 7 weeks post-exposure, infected mice had more Elastipase species, Bacteroides, Thetae, Teomicron, and less Turacibacter species. and Ligolactobacillus species than uninfected mice. At 10 weeks, infected mice had more LSTP species and fewer Murray Bacillacea species.
Just rolls off the tongue.
Just rolls right off all those. But yeah, so it's really, I mean, there'll be a deeper dive coming up on This Week in Parasitism. So stay tuned. It'll be like a few weeks in the future that I discuss this. I think 2 weeks from now or something, we'll be recording that. But really going into this whole, I mean, I love this whole concept of a parasite affecting behavior. I mean, affecting whether you're anxious or fearful or whether you have compulsion or even if you can learn things. Kind of amazing. This idea that it might actually be doing this by manipulation of the fecal microbiome.
Yeah. Yeah. I was searching the different tasks that the mice have to do. And so since I already pulled it up, I'm just going to read it. So the Morris water maze task, I guess, is a widely used behavioral neuroscience test for looking at spatial learning and memory in rodents. But there's like a circular pool of water, and they have to find the escape platform by using different spatial cues. So now I know that and saw these little pictures of the mice in little circular pools.
Yeah, mice do not like being in water. And so the platform, when I've seen this, it's below the surface and it's clear.
Yeah.
So you can't see it. They have to like know where it was. And so they've got to get back using spatial cues to where that was.
Interesting. All right. And I think I have our final paper from today. I pulled this from Eurosurveillance, Molecular Detection of Toxoplasma gondii in Ready-to-Eat Salad Mixes, Multi-Country Survey using a validated and harmonized standard operating procedure, Europe 2021 to 2022. So, as everyone probably knows, but I'm going to repeat anyways, toxoplasma can be acquired by eating raw or undercooked infected meat, which is what everyone thinks about, but it also can be transmitted through eating unwashed fruits or vegetables that are contaminated with the parasite. And so, using molecular methods, the authors found that toxo was found in 4.1% of 3,293 ready-to-eat salads from 10 European countries. They found that sampling in the winter season, sampling and packaging of salad in Northern Europe, and salad grown in Western Europe were associated with detection of toxo from salad samples. And so I pulled in this figure that outlines the design of the paper, but also has a map of the participating countries. I just wrote a note to myself. This is probably one of the only times that you can use a lot of emoji in a scientific paper and it is relevant, which I very much enjoyed. So this is fascinating. And, I think we probably still have to, there's more to learn about the systems and how this could be prevented, but just an idea of, potentially encouraging people to wash. They wouldn't normally do this, wash those ready-to-eat salads, particularly if they're at high risk. So I'd say pregnant women, maybe some of your immunocompromised patients. I also brought this up because I have very clear memory of a new congenital toxo eval with a mom who was vegetarian. She's like, there's no way, I read about it online, there's no way I could have toxoplasma because I don't eat meat. And how we had to talk about how it doesn't have to be meat. It can be on fruits and veggies and other things. So anywho, there's a map of the participating countries there highlighted.
Yeah, I mean, they say ready to eat, but I guess ready to eat if you don't mind getting a little toxo in your...
I know, it's like, it's like exactly the opposite. People are not going to wash those specific types of
salads. Yeah, they're ready to eat. They're just putting it in
exactly.
the bowl. So what are we thinking? Like, what is it? Cats are urinating on the lettuce or something, and they're not washing it off, or what? How does it get in there?
I don't know.
I guess we have the issue out west where it gets in the runoff because maybe there's cats at some level, and then and then you get heavy rains, and then it goes out, and poor otters get it. But yeah, this is one of those things. Like there have been cases where people got toxo from eating deer, right? How did the deer get toxo? They're sort of supposed to be vegetarians, but no, it could.
And depending, I guess I didn't dig in to see. I don't know if it I don't remember it saying like types of things in salads, but I think also depending on what's in there, they're probably not the easiest things for washing in the first place, or like maybe, sprout oriented things, which are hard to really get rid of microbes anyways before eating.
Yeah.
But interesting. So yeah. All right. Well, that brings us to the end of this podcast. As always, the references for this show are available at microbe.tv, the home of our growing multimedia empire.
You can find the Infectious Disease Puscast at Apple Podcasts, microbe.tv/Puscast, or grab it with your favorite podcatcher or on YouTube, and then make sure to subscribe, like us, ring the bell, and leave comments. We love to get your questions, comments, and paper suggestions. Send them to puscast@microbe.tv. If you like what we do or you just want us to keep doing it, consider supporting the science shows at Microbe TV at microbe.tv/contribute, or go to Parasites Without Borders at parasiteswithoutborders.com and click on the donate button.
I'm Sarah Dong. You can find me on Blue Sky at Sarah Windong or at febrilpodcast.com.
I'm Daniel Griffin, and you can find me at Columbia University Irving Medical Center or at parasiteswithoutborders.com, as well as on the other podcasts, This Week in Parasitism and This Week in Virology Clinical Updates. And as always, thank you for this most interesting consultation and allowing us to participate in the care of this most difficult and challenging case. We shall continue to follow along with you. Thank you, and dictation, and goodbye.
Thanks for listening. We'll be back in 2 weeks. Another podcast is infectious.